Right, so one of the things that we oftentimes think about in Machon and Dvir is how other modalities can integrate with DBT. I guess in a sense, try not to be closed-minded or purist. I suppose within the sentiment of being dialectical, thinking about how things can come together and work together. So this is one attempt at doing that. All right, can I just see by a show of hands how many people are relatively familiar with DBT? Oh, that's good. Okay, so we can move through these slides a little bit quicker. All right, so a little bit of background in both DBT and EMDR. How about EMDR? A show of hands also? All right. Okay, I understand why you set for this one. Okay, so DBT, like EMDR, was developed in the late 1980s by Marshall Linehan. Marshall Linehan actually has a fascinating autobiography called The Life Worth Living that's worthwhile reading. It gives you a little bit of a window into her thinking and also where a lot of her skills came from. She herself went through a lot when she was, I think, 17 years old. She was in a psychiatric ward for quite a long time. And she goes through her own experiences of things that were helpful and not helpful. So what she was trying to do was meeting the needs of a population that was extraordinarily complex. People that were suicidal, high risk, engaging in risky behavior, parasuicidal behavior. And at that time, there weren't a whole lot of choices for treatment. Interestingly, there were a lot of people that came independently, sort of converged in the late 1980s. Right, so I think Jeff Young in schema therapy was around the same time, trying to treat the borderline community. Marshall Linehan, Otto Kernberg and his group doing transference-focused psychotherapy. So there's clearly a need within the world and the world of mental health. The aim of DBT, essentially, well, like Benji was mentioning, is to cultivate wise mind, to be able to live in a wise-minded state in order that one can live a life worth living. That I have a sense of what my values are and have the ability to engage in life in a way that's regulated and steady and consistent. There's a sense of self-respect and ability to stay connected and close with other people and live a life worth living. Interestingly also, Marshall Linehan introduced, or I would say highlighted the importance of the therapeutic encounter, right, in behavioral psychotherapy that wasn't really focused on or high premium wasn't placed on it, or in behavioral psychotherapy, or even later in CBT, the way that was classically practiced, there wasn't a strong focus on the therapeutic relationship. And I guess not surprisingly, when working with the borderline community, Marshall Linehan did place a focus on that. Not everybody knows this. There are actually 3 phases of DBT. Usually when people speak about DBT, they think about the first phase, which is skills acquisition, right? So a lot of us know the 4 modules of DBT. Some of the basics. That's just meant to be stage 1 of putting out fires, working with somebody. I think the analogy that Marshall Linehan oftentimes gives is of a burn victim, right? So their skin is extraordinarily sensitive. They can't tolerate a whole lot. They really need to be well-resourced in order to be able to cope with life. So that's stage 1. So dealing with suicidal behaviors, parasuicidal behaviors, what we call therapy interfering behaviors, and then quality of life interfering behavior. She even has a hierarchy of treatment that's communicated to the client early on, that every session is going to work to that hierarchy. Right? If there's suicidal behavior, that takes precedence over everything else. If there's no suicidal behavior, then it goes into parasuicidal behavior. If there's none of that, then it's therapy interfering behavior. If none of that, then it's the quality of life issues that a person came in to work on. Phase 2, which is really where we find there's space for a lot of integration, is on reprocessing trauma. So Marshall Linehan, herself never created a protocol for treating trauma. Well, I shouldn't say it that way. She never created a protocol for processing traumatic events from the past. I think later, over the last 5 or 10 years, somebody did within the DBT community create a DBT approach to processing traumatic events. I imagine that the reason why Marshall Linehan didn't feel as much of a need to do it is because other things already existed. Even within the behavioral world, Edna Foa's prolonged exposure, for instance, Shapiro had already introduced EMDR to the world, so there were people that were sort of taking care of phase 2. Then there's phase 3, which is really consolidating all the work, right? The work of phase 1, the work of phase 2, and then consolidating and solidifying the gains that have been made and continuing to build that life worth living. Okay, I'm not going to go into details, but these are the 4 main modules of DBT: mindfulness, distress tolerance, emotion regulation, interpersonal effectiveness. Like Benji had mentioned, Marshall Linehan always starts with wise mind. A big part of starting with wise mind is mindfulness. right? And the reason why she does that is because all the other skills being practiced effectively is really contingent on a person being able to be mindfully present, right? So if we think about emotion regulation and being able to identify what I'm feeling, make space for what I'm feeling, check to see if what I'm feeling actually fits the facts. I need to be mindfully aware to do all of that. If I am avoidant and not open to my experience, so I'm not going to be set up well to do all of the other skills. I believe that in many groups, when teaching DBT, they'll even go back to mindfulness in between every module. So it's so important, it's so foundational that it's constantly being gone back to. Distress tolerance is really SOS skills. So this is a little bit of a DBT hazard. Distress tolerance skills are relatively easy, right? So they are skills like dunking your face in freezing cold water, right? It's not that hard, it's uncomfortable, not that hard. Or paced breathing or intense exercise. Stop skill, not doing anything in the moment, freezing, not moving a muscle when there's a crisis urge that's surfaced. Distraction, improving the moment, self-soothing, right? So these are relatively easy skills, and it's easy for both client and clinician to sort of use that as a default. And the idea behind DBT is not to give people Band-Aids. Ultimately, it's to help people be able to make contact with what they're feeling, determine is this feeling in line with reality? If it is, great, how can I express it in an effective way? And if it's not, how can I change it and what can I do? So it involves much more what we would call reasonable mind. In DBT, it's much more difficult, and that's what we want to make second nature for the clients, not to be reliant upon distress tolerance skills.
I think there's also an added frustration for clients because many times they'll come in and say, I tried this and this skill, I did this, I did the stop skill, I dunked my head into water and it never helped. Like, the skills are not helpful. That's like a very common reflection that clients have about the distress tolerance skills. And so as clinicians, we also want to focus on emphasizing that these skills are not necessarily to make you feel better, but to prevent things from spiraling down and making things worse. And then once we stop the spiral down, then we can help you to focus on the next module, which is emotion regulation, helping you feel better, helping you get better.
Okay. All right, I'll do one more. EMDR also was developed in the late 1980s by Dr. Francine Shapiro. I guess at this point it's like EMDR myth and legend, the infamous walk in the park. Francine Shapiro one day was perturbed by something, and while meditating on it, she's walking through the park and noticed that she's feeling better. She said, well, hey, that's interesting, because she was being mindfully aware of her experience. She said, well, what's going on over here? And she noticed that she was moving her eyes back and forth from two different, I think, whatever was on the right side of her path and the left side of her path. She said, well, is that it? Is that what's contributing to my feeling better? So she tried to do it consciously, think about something that was bothering her, and then move back and forth, and she found that it worked. Then she started to do it with family and friends, and then later with clients, and the rest is history. We'll get to a little bit later on, some theories as to what might be going on, why that might work. But at this point, there's a lot of research that's been done that has targeted that as one of the core processes in allowing traumatic memories to be resolved. The goal of EMDR, I guess essentially, at the end of the day, is also to live a life worth living, but it's to help a person stop living in the past while in the present, right? So there's kind of this time travel effect that old memories that have not been processed are frozen in time, haven't been digested. So in the present, when there's anything that looks like, smells like, feels like that old thing, it's enough to activate those old, what they call memory networks, and then a person's transported back in time. So even though they're in the present, they're experiencing the present as if it was this past event. So the goal in EMDR is to help a person live in the present moment and not experience that time portal sort of phenomenon. There are 8 phases in EMDR, in contrast to DBT's 3. Again, I don't want to go into too much detail over here due to time constraints, but I'll run through them quickly. The cute little mnemonic device that's been developed is Harry Potter and Dumbledore and Big Cheesy Relationship. So if you take the first letter of each one of those, so it stands for each one of the 8 phases. EMDR starts with history taking, like most good psychotherapies. Phase 2 is preparation, which is a lot of what we'll be talking about today. I one time heard somebody compare EMDR to a surgery and taking a scalpel and opening somebody up, which is, I think it's a pretty good analogy. And if you don't have the anesthesiologist in the room and people that are monitoring the person, so you're running into deep water and it can be dangerous. All right, so in EMDR, what we're trying to do is really open up the wound as large and as wide as we possibly can, while maintaining mindful attention. Again, we'll speak more about that. But doing that means that a person needs to be able to tolerate the difficulty that comes along with it. It's not an easy process. So phase 2 is really focused on helping prepare a person build the ego strength to tolerate that kind of experience. Phase 3 is assessment. Is going into a particular memory that's going to be worked on and identifying thoughts, feelings associated with it. So really opening up the wound, if you will. Desensitization is the reprocessing part of EMDR, trying to help a person, I don't want to say let go of, but experience the past in a different way than they have up until this point. Phase 5 is what we call installation, which is integrating a new perspective on reality while maintaining focus on that old memory. Right, so if they were, in the beginning of the work, they were holding on to a memory and the core belief that was associated with it was, I'm an absolute failure. Now the goal is to help them be able to look at it and both think and feel that it's true, that I am doing the best that I can, or that I've been successful in life, or whatever positive cognition is appropriate. Phase 6 is body scan, and EMDR really want to make sure that the work has actually been done, not just to say, well, okay, we've done the reprocessing, their SUDs are down to a 0, let's move on. They'll ask the client to hold on to the old memory, to hold on to the new positive belief, and scan their entire body. Is there anything that's coming up at this moment that's still saying, I need attention? Phase 7 is closure, right? Grounding, psychoeducation, consolidating some of the work. And then phase 8 is reevaluation, which happens at the next session, checking in on how the week was, checking in on that particular memory we worked on, checking in on the theme that we're working on and as it was expressed over the course of the week. Okay.
Okay, so the theoretical backbone to EMDR is what we call the AIP model, the Adaptive Information Processing Model. And louder? Okay. Yeah. Does it work? Okay, I'll try and speak a little louder. Okay. So what we believe in is something that we call neuroplasticity, that the brain has the capacity to consolidate information and also to heal. Just like the body has the capacity, after you cut yourself, it has the capacity to heal. And what trauma does, it kind of disrupts the system. And so what EMDR does, it comes in and it successfully kind of cracks a pathogenic memory, which is a memory that generates pathos, which are current symptoms that clients experience in the present moment. And you crack that memory open and you discard, it sounds like a surgery, and you discard what's not adaptive and you keep what's adaptive, right? There is some information that is really helpful to learn growing up, to keep safe, to maintain stability, to learn things about the world that we really want to keep and maintain, and there are certain things that we really want to get rid of. And so there's this Hebb's axiom that says neurons that fire together wire together. What happens is, an example of this is somebody who, as a child, will hear from a parent, you're a bad person, you're worthless. That message will generate in their body and create a sense of shame potentially, and also that feeling inside, a sensation inside, that gut-wrenching, tight stomach that comes with it. And so whenever they have an experience that generates a similar symptom to that, a feeling, emotion, sensation, that again gets wired in that same file folder in their mind and kind of generates that exact same feeling from before. And obviously the more intense the symptom is in the present, it also creates this idea or knowledge from as a clinician to understand how early on this started. So the past becomes present, and what happens is that memories develop into this memory network of similar emotions and sensations, and then it kind of wires together. And so what we want to do is kind of unblock that and create new healthy and new adaptive neural networks to create adaptive information processing in the present moment. So how does that overlap? When the processing is successful, the previously disturbing memories are neutralized and effectively integrated with other similar experiences. And so that's why we take that negative cognition and we crack it to a positive belief, right? You can go from I'm worthless to I am worthy of living, in order to be integrated into the present moment. And so what we have in EMDR is what we call bilateral stimulation, right? We're activating a memory, we're attaching that negative cognition with it, and we're stimulating a client using bilateral stimulation, which what reportedly Francine Shapiro was able to understand. It reduces the vividness of the images and intensity of the emotion. It's really a miraculous experience. It's not magic. It's really not magic, but it feels magical in the room, where a client can go from a subjective unit of distress. They're in so much distress, they can't even bear to look at that image. They can't bear to even experience that feeling that the memory generates in their body. And they could go from a 10 of distress down to, they do go from a 10 of distress down to a 0. It really is a miraculous experience. And through bilateral stimulation, which could be many different forms, we'll go into what 2.0 has created, and it reduces the intensity of the emotion. So we have eye movements that are helpful, that's part of stimulating. There's alternating tones, there's tactile stimulation, you get really creative in the room. I think we all are aware of that as clinicians. We really do have to have a creative spark to ourselves where we're constantly pulling and bringing out things. And I think in EMDR specifically, it's not just, it doesn't go by standard protocol only. Sometimes you really have to be where the client, not all the time, you have to be where the client is at in order to help stimulate and reduce the vividness. So something that recently came up, Ed DeJong and Susie Matthewson together, they created something called EMDR 2.0, which capitalizes on the brain's natural reconsolidation process by combining traditional EMDR and additional interventions, which helps compound the ability to reduce the vividness and the emotionality of the traumatic memories. So we found that a lot of times when there's such combustible material, when there's material that really triggers a sense of where the past is present, we need more than just follow my fingers and go with that. Clients, it's not enough for them to hold that vividness of the memory and also do the processing work. And so 2.0 comes in and really cracks that memory. You go to the absolute worst case, the absolute worst image, and you crack that by using added forms of stimulation. So you can have your fingers are going, and you can have the client doing math examples and doing the V-step while you're doing this. And what that does is automatically the brain can't hold the capacity for such an intense feeling to be distracted by so much going on here. And so something has to drop, and what happens is the intensity and vividness falls. So we have something called the window of tolerance, which Dr. Danny Kahn explained it in a really beautiful way. And the way it's described is that you find adaptive information and maladaptive information, right? We all have neural networks within our brain system that helps us with, learning life and figuring out what our next steps are going to be. And that is adaptive information and also maladaptive information. And the memories are stored, that are trauma material, are stored in trauma space. And they're experienced in the here and now. He described it as if there's a general who's standing on top of your head and pressing this panic button when there really is essentially no fire. And so the body has to learn and integrate what it means not to be in danger and not to allow this button to be pressed on top of your whole system that really, really takes you away from the present moment and brings you back in the past. And so our goal within EMDR is to help clients stay within their window of tolerance, to be able to generate information and create it back into adaptive space in your brain in order for you to process. So it takes away that traumatic combustible material and then it reprocesses it with adaptive information. So, our goal is to take those pathogenic memories, and EMDR allows that normative process to happen, right? Instead of your body going into complete trauma mode, right, where you have that those emergency sirens blaring and you feel like you're in absolute danger, or there's the three main spaces that trigger a sense of trauma, a traumatic response is danger, a lack of control, and loneliness. And so when we target that with safety as a clinician within the room, where we have connectedness within our relationship, we give clients the ability to control. When it's too much, they say stop. When they're not coping, they tell you, and you value that, and you work together with them. That's really important. And then connection as well. So the safety, the control, and the connection are really the three keys in helping clients maintain and stay within their window of tolerance. Okay. So now we're going to segue into how EMDR and DBT integrate, right? That people kind of view these two modalities as separate, or like John described, right, where it's like, okay, DBT is just about the skills building, and then that's it. And once you build skills, then you don't really integrate it any further in your work. And so there's something really beautiful about acknowledging how they really do form an alliance together throughout your work. So philosophically, you can notice how they both overlap is where they share a deep belief in the human capacity of healing, right? Where you have DBT, you have that assumption that we believe that everyone wants to heal. And in EMDR, you have the physical information processing, like any other body system, is naturally geared towards health. So both of them hold the belief in the human capacity of healing. And to hold that as a clinician is also really helpful when you come in with these two modalities. And then you have the clinical integration, where DBT first builds regulation and emotional tolerance, and then EMDR comes in and allows the reprocessing to happen. But obviously it's not so linear, and you'll find many, many times where you'll start with the processing and then segue back to stabilization, and then go back there and segue back. And that's really a dance as a clinician that we really see we use all the time in the room, right? We can't just have an agenda and go with it. That's the connection where you really feel where your client's at and go with what they need. So we have the self-regulating skills, and once you have that skills building, which is in phase 2 of EMDR, then you know you can go into really bringing out that target selection that you have, going through and being able to stimulate a client because you believe and you know that they have the ego strength to be able to maintain whatever they're going to have to crack and get through. Okay.
Okay. So we want to go through using the 8 phases of EMDR, taking a look at what EMDR looks like and how DBT we think can add to the process, or bolster the EMDR process. So phase 1 in EMDR and DBT is an intake history assessment, like it's phase 1 in all good psychotherapies. The general things that they're covering are what we all hopefully cover: identifying presenting problems, therapeutic goals, psychiatric history, et cetera, et cetera. Where EMDR starts to get more specific is being able to conceptualize the client from the AIP perspective, which means that in EMDR, they're looking at essentially 4 basic categories of pathogenic beliefs. Safety, the sense of I am not safe, defectiveness and responsibility, guilt and responsibility, and power and control, right? So, and the thinking, I guess what Francine Shapiro found was that most people will fall into one of these 4 categories, right? So if you think about the affects that are associated with them, it's really guilt, anxiety, shame, and fear, right? Which is probably not all that foreign to most people sitting here. Those are usually the affects that come in that can make life quite difficult. So when sitting across from somebody looking through an EMDR lens, we're thinking about which one of those 4 categories is this person falling into, and are there more than one, right? Sometimes single memory can have all 4 categories inside it. It's usually the more complex cases. But being able to conceptualize it allows a person to have a roadmap in terms of how to intervene. Being able to identify relevant memories in the client's life, positive and negative. The positive for being able to integrate adaptive information into the maladaptive information. And the negative, because those are the things that we're primarily looking to work on in at least the past aspect of the EMDR work. Identifying skills deficits. This is where DBT comes in. If a person cannot tolerate their own affective experience, EMDR is not going to work. And I think that oftentimes, when I've heard people come into session and say, look, I've done EMDR therapy in the past, it really didn't do anything for me. And sometimes I'll ask them a little bit more about it. I say, yeah, they kept asking me the same questions, just told me what he wanted to hear, and we moved on. Well, it's not going to work, right? If those memory networks are not lit up in the EMDR work, then what has to happen is not present. You're not working with the thing of change. So it's not enough to intellectualize and to talk about, from a narrative perspective, what happened. I need to be able to feel it as I'm talking about it. Once I can feel it and then the memory networks are lit up, so to speak, then I can reprocess it. So lacking the ability to do that, not having the ability to maintain what we call dual awareness in EMDR, which translates into mindfulness everywhere else, means that I really can't do the EMDR work effectively. Okay. The only real thing that DBT might add to this stage of work is what we call a chain analysis, right? So looking at the problem behavior and trying to get a very clear sense. It's kind of like a functional analysis, for the CBT NICs. It's a very similar sort of thing. It's just a little bit more tedious and drawn out. So we want to look at the problem behavior, the prompting event or the trigger for the problem behavior, and then all the links in between. So all the thoughts, feelings, sensations, urges, behaviors that link those two things, so we can really understand what is going on. Okay, this is really, I think, a lot of the meat and potatoes of DBT and EMDR integration. There's a preparation stage, building stabilization, helping clients become resourced, right? So a lot of what DBT is doing can be setting people up to do the more difficult work. And again, if you recall from the earlier slide, that's what Marshall Linehan was trying to do, helping a person build resources so they can move on to phase 2, which is the trauma work, and then to phase 3. So we spoke a lot about mindfulness being a core skill within the preparation phase of EMDR. It's important both at the beginning and throughout, right? To be able to maintain that mindful awareness throughout the EMDR process, regardless of what comes up, not to, in ACT terms, engage in experiential avoidance. That no matter what comes up, I can maintain that dual awareness, I can make space for it, and I can move throughout it. So oftentimes what we'll tell clients in EMDR, that it's like a train passing by, right? Which is an analogy and imagery we'll use in mindfulness as well. You are here now in the room with me, looking back at all that old stuff, allowing it to pass through. So we don't want them to regress and go back and get sucked into the old stuff, right? Some approaches to trauma will do that. In schema therapy, when they do imagery rescripting, they'll ask the client to imagine the experience from first person. Be that little boy or be that little girl. What are you thinking? What are you feeling? What's going on for you? EMDR is very different. We don't want the client to go back and regress and go back into that state. We want them to be in their wise-minded state in DBT terms, or their healthy adult in schema, or their self in IFS terms. I'm here in that healthy adult self, looking back at all that old stuff and allowing it to pass through me. But I don't want to regress. So mindfulness, I think, is key in doing that. A nice way of thinking about this, like Shevi had mentioned from Donnie Kahn, is a window of tolerance. I want to expand that window of tolerance enough so that I can put all this trauma stuff inside of it, and I can stay within the window of tolerance even while it's activated. Distress tolerance skills, like we spoke about earlier, are really for, we call in DBT, it's a skills breakdown point, when affect becomes so intense that I can't really stay in that healthy adult perspective of life. I'm too overcome by my emotions. I'm at risk of regressing, or I've already regressed. Now what do I do? So in EMDR, we're also at risk of that, right? We might start off and they're able to maintain that dual awareness, but as the work goes on, they might hit on something, a new memory might come up that they didn't anticipate, and now they're outside their window of tolerance and there's an abreaction in the room. So they might be curled up in fetal position on the floor of your office, and now what do you do? So we need resources for that as well, and I think that's where the distress tolerance skills can really help. Marshall Linehan, I believe, introduced them initially to help provide a substitute for things like cutting, which provides immediate relief. It's very visceral and actually very effective for a lot of clients. It's just not effective long term. So things like dunking your head in cold water, which I've never done that during an EMDR session, might be interesting, allows also this very immediate visceral sort of relief for the client. So being able to have things like deep breathing, like grounding techniques in the room, to pull a client back in EMDR is extraordinarily important. The goal in EMDR, like in DBT, is not to stay with the distress tolerance skills. So if somebody's abreacting in the room and there's still sufficient time in session, we don't want to pause session, pause the reprocessing, and say, okay, this is too much for you, let's spend the rest of session processing. We want to pause, help bring them back, get them back into their window of tolerance, figure out what they need in order to go forward, and then continue. And it's the same thing in DBT. Use the distress tolerance skills in an effort to get back to the emotion regulation skills. We want to help clients move. We want to help clients change. Right? It's not just about providing instant relief now, so you're not feeling those intense emotions. We're doing that in order that you can change, you can move on.
If you don't have a sink of water, you could grab ice cubes. Like, that's an example also of using your creativity, just helping clients not get carried away and coming, just bringing them straight back into their window of tolerance, and you can join them in that. Like, you can create your window of tolerance to help, use your window of tolerance to help them. So you quickly run, grab those ice cubes, hand it to them, and get going, or get movement. If they're frozen, you want to get them moving, get them going. So it's, again, there's the creativity there, but using a moment of being able to tolerate the distress in order to quickly bring them back.
Yeah. An interesting point, and this is part of the evolution of EMDR, is in EMDR 2.0 is actually not a whole lot of preparation. Maybe that's a presentation for a different time, but essentially what they seek to do is flood the client with stimulation. So there's not really ample room for them to dissociate or to regress. They are so flooded with solving math problems or moving around in the room or spelling things backwards while at the same time holding on to that old memory and pathogenic belief that it doesn't really require the same sort of preparation. So an interesting thing to think about. One more thing that we thought that DBT could offer EMDR, at least the preparation stage, are diary cards. So EMDR has a TICES log, TICES, tracking triggers, images, cognitions, helping a client maintain some sort of mindful awareness of the problem they're coming in with, right? So if what I'm coming in with, I'm super shy, I can't speak in front of other people, I can't present anything at work. So Shapiro would give somebody a TICES log and help them track that over the course of the week and then bring it in with present day examples in the next session. Diary cards are similar in the sense that we're also helping clients track what's going on over the course of the week. We're tracking the problem, we're also tracking progress. So it helps the clinician get a sense of how much the client's moving along or not. Okay. The assessment phase of EMDR, again, is really only possible after there's been that sufficient preparation and they're resourced well enough. They've got enough ego strength now where I can start to do the work. So phase 3 of EMDR is really the beginning stage of going into the memory and reprocessing it, which means we're taking out that scalpel and we're opening it up. So what that would look like is asking a client to think about that memory that we've chosen to work on, and I want you to think about the worst aspect of that memory. So hold in mind that worst image of that memory. And the idea is not to be sadistic and put the client through difficulty. I want to go right to the core, activate as much as I can of that negative emotion, really get that negative thought associated with the image present in the room, feel it as much as you can in order that we can then go in and do the healing work. So again, in order to be able to do that, it means being well resourced. We thought this is also where dialectics can come in, both being able to be in that maintain that adult perspective in the room, maintaining that dual awareness means that I am here, consciously aware of the fact that I am in the present, and while at the same time balancing, allowing all that old stuff in. So holding both of those things at the same time. It also means during the assessment phase, we ask clients, what it looks like is we'll say, think about that worst image of that worst memory. And then we'll ask them what negative belief about yourself goes along with that image as you think about it now. So I don't know, it's me as a second grader, my teacher humiliating me in front of the class. What negative thought goes along with it? I'm a complete failure. Then we'll ask a client, what positive belief would you like to believe about yourself? Or I've heard people say, what do you know about yourself to be true and can't yet feel? So it might be that I'm okay as I am. So that again requires dialectics, that I can both think about and feel that old experience and at the same time at least introduce the possibility of a new way of experiencing or thinking about this old memory. We'll then ask clients to identify what they're feeling, how strongly they're feeling it, their SUDs, their subjective unit of disturbance, how difficult, how intense this whole thing is for them, and then asking them to then hold on to that image and start from there into the next stage of reprocessing. But again, if a client is unable to genuinely activate all of that and you jump into the next stage of desensitization, nothing will happen. It'll be an intellectualized process, and they'll probably come out feeling like, EMDR has got nothing to offer. I tried and it didn't work. So I really think that it's super important to be very in tune with the client, particularly during the preparation and the assessment phase, to see, are they really ready to go into the work? Are they really open to feeling what's going on? Are they really able to tolerate feeling it in the moment? Or is more work necessary? Until 10:30? You want to switch?
If phase 3 doesn't really work, quote unquote, if phase 3 is not really progressing or moving forward, that's when, what John just said, to go back to say what's getting in the way. And we call those, is there a blocking belief getting in the way? Is there something that's holding you back? Are you not resourced well enough? Are you experiencing experiential avoidance? Like, what is going on in the room that's not allowing you to get into that next phase? And so that's where also DBT helps, like using that mindful awareness as a clinician and also helping them become aware of what's holding them back. So then we're going to phase 4, which is desensitization, and that is where the processing happens. Where phase 2, you'll have a state change where clients can develop ego strengths. In phase 4, we believe that there is a trait change, where something actually changes inside their psyche, their belief about themselves. And so that's where we target the memory, and clients can go from a subjective unit of distress of 10, or wherever it is that this memory generates, down to a 0, utilizing bilateral stimulation. And where DBT can be helpful in this phase is, again, through mindfulness. You're asking clients to constantly maintain natural awareness, right? You're processing, and then you're asking them what comes up for you. That generates a sense of being mindful. I don't know what's coming up for me. In order to be mindful, you're able to access and acknowledge what's actually coming up for you, and then you're telling them, go back in, go with that, go with whatever's coming up for you. And in order to do that, you really do need to be mindful of any thoughts that come up, any sensations, any feelings, anything that's really generated throughout the processing. Requires mindfulness. And what we're also bringing up in this phase is radical acceptance, where clients are showing up and they're demonstrating a sense of willingness to turn off that struggle switch and allow for somatic activation, right? You can be avoidant and you can say, I can't even look at that, right? So many times you'll hear clients who say, like, I can't handle it, I don't want to do this, and they're showing willingness and radical acceptance to be able to turn that struggle switch off and allow for activation to happen, which is really scary, especially if your coping mode is avoidance. To be able to go head on and show willingness to do this is really a remarkable shift, and that takes a sense of radical acceptance. And then, if needed, we have crisis intervention skills to allow clients to quickly come back to their window of tolerance. Again, we don't want to create this pseudo window of tolerance where clients come out and then we bring them back in, and then they come out and we bring them back in. That's obviously not the goal. But in such a circumstance, when we're doing desensitization and we're noticing dissociation happening or avoidance coming in, or there's some sort of blocking belief, sometimes we do need to engage in self-soothing skills or distracting or improving the moment, right? You could use that as a stimulating effect in 2.0, right? Where if a client's starting to leave the window of tolerance, you'll quickly say, okay, stand up with me, let's do the box step, or What 3 ingredients do you put in your chicken soup? You'll just really try and like engage them from a different place, which you can call a distracting skill or an intervention that is tolerating distress or bringing them back into the window of tolerance. Whatever it is, you really want to put on that creative side of you to be able to bring them back, and that's really where DBT comes in as well. You know, you can call that 2.0, you can call that distress tolerance skills. It's really bringing them back into their window of tolerance. And then we have phase 5, which is installation, and once we crack that memory, that pathogenic memory, and we bring up the negative belief and all the feelings that come with it, and we do the processing, at this point we are strengthening that positive neural network, right? We've discarded all that negative energy, all those negative beliefs that are associated with it, hopefully, and we can come to installation where we're growing that positive neural network associated with the target. That's where the adaptive information comes in. And where we can integrate DBT is, again, mindfulness of current emotion, where we tell the clients to notice with curiosity any emotions that come up. And obviously this is without judgment. And you can see how mindfulness is literally laced into every phase of EMDR. You can't exist, honestly, processing anything without it. And then we have phase 6 is the body scan. And what the goal of body scan is to process any implicit memory network through the somatic awareness. You're asking clients to notice, scan, literally take a laser beam through their body to scan whether they have any negative residual trauma that's left there, right? And many times it does come up where there's some sort of tight stomach or there's some part of the memory that's lodged somewhere in the body that's holding it, and that body scan kind of just cracks that last little piece and laces in that positive cognition. So it's really that phase before we're fully installing, before everything's fully integrated. And where DBT comes in is, again, you have to be able to be mindful in order to notice anything in your body. If I don't even know what a sensation feels like in my body, then how can I be mindful of it, right? And many times you'll even, when the first time you're meeting a client, you can ask them to notice, or what does that feel like inside? And they'll look at you with a blank stare, right? And so that, just generating that question allows them to be mindful of their sensations, of their thoughts, of their experiences. And that's really where DBT is integrated in this phase. Okay, and then we have closure, phase 7, which is to stabilize. Obviously, we don't want to clients to leave on an escalated, aroused state. We want to stabilize and debrief, hopefully. And where DBT is integrated in this phase is to obviously reinforce the resilience and encourage the use of open mind. Just to notice, we say this all the time, right? Notice any shifts over the course of the week, just to carry them through. And to engage in cope ahead. If you notice any arousal, any this, any that, to encourage stabilization, which is all the phase 2 work that you really did. You know, you have the resources, you have the capacity, I believe you could carry through, and I'll see you next week. There's also that resilience that you're giving over to them, that you believe they'll get through this. And what John brought up before, where you can encourage clients to use the diary cards or the Tysis log to help track in between sessions, right? Just to give them the ability to be mindfully aware of what's coming up for them, right? You can have clients who come in many times, even when the processing session was very successful, they can come in the following week and say, I don't know, it was a long week, I don't even remember what happened an hour ago. So the log really gives them the capacity to remember, detail, log what's really going on for them moment to moment. You obviously don't want them to nitpick and pull apart things, but you also want them to remember, so that there's follow through. Okay, and then you have phase 8, which is reevaluation, and you check progress, you assess new targets, right? The progress is both micro and macro. You want to clients want to know that they're getting somewhere, right? They want to know that you're slashing things off on their treatment plan and they're moving somewhere. So when you check progress, you want to check their global progress on the treatment plan, and you also want to check, can we go back to that specific target memory? Can you hold it in your mind? Is there anything that comes up, any residual trauma that comes up in your body, in your mind, any sensations? Are you emoting? Obviously, the way Danny Kahn brought it up is like when you pick up a very triggering picture. It could be, let's say, of the Holocaust that happened, right? When you pick up a picture and you look at it, obviously you're going to feel something inside. It's a yucky, horrible, it elicits something, some sort of reaction to that image, but then you can put it straight back in the album. There's some sort of disconnection to it. And so that's what we want, where you can look at that traumatic material and say, that was yuck, that was horrible, that was awful, and I'm able to put it back in the album. It was part of my life. It's over now. I'm here. And that's really the ability to check that progress, to be able to assess whether clients can do that. And where DBT is integrated in this moment is, again, the use of diary cards. We said this last time to help track symptom reduction, right? I want to know that they're getting better. I want to know that they're not having this nightmare anymore, that the symptoms are not increasing, and to, again, revisit that target selection and make sure that it's going towards your treatment goals together that you've planned. Okay, do you want to start?
Okay. Just to share one thing that was going through my mind while Shevi was speaking, is that there was a machlokas between Marshall Linehan and Otto Kernberg around DBT versus psychoanalysis when it comes to treating borderline personality disorder. And Otto Kernberg and his team claim that DBT doesn't lead to personality change. Right? You're not really going deep enough. So you're looking at the core. So when you think about a chain analysis, you're looking at prompting events, you're looking at thoughts, feelings, behaviors, or even identifying vulnerability factors, which are what are the experiences in the past that might have led to you perceiving the situation today as you are. But then you're staying on a behavioral level. You're changing thoughts, you're changing feelings, you're changing behaviors. So Kernberg said, well, that's not going to lead to personality change. There's no deep insight-oriented work that's going on. You're not going back to the past. So you're just staying superficial. Marshall Linehan challenged him and his team, and she said, well, what's the definition of personality change? So they came up with a definition, and I never looked into this myself, but in her book she writes that she took their definition and she ran thousands of clinical trials, and she proved them wrong, that it actually led to personality change. Okay, we'll take her word for it. I think that with EMDR and DBT, you can ask a similar sort of question, right? EMDR goes pretty deep, and it's looking back at the past events and digging things up. It's like, I oftentimes think about like an apartment with a plumbing problem. Right, so sometimes the problem is superficial, and you need to change the berets or change the handles, and that's sufficient. Other times it's an internal problem. You have to crack open the wall or open up the tiles, get underneath, and change things around. So EMDR is really digging things up from the bottom and changing the piping. So if doing that allows for change on the surface level, so then why would we just stay with DBT and do all of that hard work with thoughts, feelings, and behaviors if we can go underneath, solve it from the bottom, and then it won't be flooding the kitchen anymore? And I think that the answer is like we're trying to suggest that we do want to get there. It's just a question of when, right? So if DBT gives us the tools to build the ego strength to do that kind of work, so we've set ourselves up in a way that can be extraordinarily successful. So I don't think that Marshall Linehan was ever against the idea of personality change. I don't know what kind of clinical studies she was running then, but phase 2 is really going back and doing that deeper work. And phase 1 is really just about setting the groundwork in order to be able to do that.
And one's not more important than the other.
Right. All right. Thank you. So oftentimes people talk about trauma work. Trauma work is DBT, trauma. Is it trauma therapy? And I think that the answer is yes. So it might not be trauma work in the way that we oftentimes think about it, which is doing that more invasive sort of work of going back into the past. But it is helping people cope with all of the symptoms of all that stuff in the present in order to be able to go ahead and do that. Or you can't have phase 2 without phase 1. So I would consider the whole thing to be trauma work. So we wanted to present with the 2 minutes that we have left, just being able to look at a distinction between a relatively straightforward EMDR case that might not require a whole lot of preparation, doesn't require a whole lot of DBT work, versus a more complex case, a borderline client or a complex PTSD client that would require a whole lot more. You know what? I'm gonna skip the going through. So if you can think about somebody in your own practice who's relatively straightforward. I know nobody's really straightforward, but I mean straightforward in the sense that they're able to tolerate reality. They don't. Their defense mechanisms are relatively mature. Right? They're not relying on defenses like projective identification or splitting. They can tolerate reality in the present, and there's sort of this piece of their life that really gets them stuck. Right? So that would be a relatively straightforward EMDR sort of process where the sorts of things that would come up are standard, right? So they'd be able to tolerate activation, they'd be able to activate, they'd be able to stay within their window of tolerance while maintaining focus on that old event. And then things that come up would be experiential avoidance in the moment, which hopefully they'd be able to work through well enough. Blocking beliefs oftentimes will come up in EMDR therapy where something like, I don't deserve to process this, I don't deserve to move on. Other people in my family are still stuck, I shouldn't be able to move on. Feeder memories, things that a client didn't anticipate when they came in but are associated with the core memory that we've chosen to work on. Or adaptive information not integrating automatically, where we brought the SUDS down to a 0, but then when thinking back on that old memory and bringing in that new positive belief, I'm good enough, I'm lovable, etc., it still doesn't quite fit. So that would sort of be standard challenges within EMDR work of a relatively healthy client. Right, so if you think about older, I guess they still use it, psychoanalytic categories of neurotic, borderline, and psychotic, right? So something like that might be in the more neurotic realm, where they're relatively well-functioning, and there's sort of this piece of their life that gets them stuck and brings them back to old stuff. Case 2 would be somebody who, let's say, here we had Rachel, a victim of childhood sexual abuse, abused by her brother from a very young age, didn't have supportive parents, nobody to speak about it. She was alone in the abuse throughout most of her life, grows up, develops a lot of unhealthy relationships, develops an addiction. Right? So this would be somebody that if you try and go right into the EMDR work, you're asking for trouble. She's not going to be able to tolerate this sort of demands that EMDR has, and she's not going to be able to bring up the memory and activate it well enough in order to be able to do the work. She'll probably dissociate or abreact, but there won't be enough of that dual awareness in order to be able to successfully run through EMDR.
Just in her story, you can also pick up the themes, right? There's aloneness, there's lack of safety, and there's lack of control. That's just like, that should be screaming at you when she, such a client, when she presents in the room, you pick up those three, we're talking about something more complex.
Right. So this is somebody where phase 2 would be extraordinarily important. All those DBT skills that we've been speaking about would really be relevant to a presentation like Rachel's. Okay, we are over time. I wish we could take questions, but we'll make an exception for Shmuel. Okay, this is somebody who has access to memories or does not have access to memories?
Doesn't have clear access to any specific episodes that describes years of abuse happening.
Okay, so I think that this would be, the goal would be to get her to a point where she's able to make contact with past experiences, pull out a difficult memory and to start there. And it would be not working on the whole memory, maybe even working on a sliver of that memory, right? So this is sort of more recent in the world of EMDR. There's a clinician, Thomas Zimmerman, that's done a lot of really nice work. He wrote a book recently on complex PTSD and EMDR, where he's really working on presentations like that. So the idea would be, again, to really lay heavily on the resourcing, which is the approach that he takes. And then when moving slowly into the reprocessing work, but again, oftentimes working on slivers of the memory, not taking the whole thing at once.
The belief behind that is that if you don't have any adaptive neural networks throughout your system, how can you take trauma material and bring it to a new adaptive realm? If you have no adaptive information to cope through anything, then you really can't there's no space for adaptive information. So you have to first grow that area, right? There's no window of tolerance, you want to grow that area, and then you can bring that traumatic material to that window and crack it and work together with it. So there is emphasis on building the adaptive information processing system within the brain, and then you can go ahead and, you know, these clients can't even create a timeline of their life. There's so much fragmentation going on and so many parts of them that are all over the place. You really need to first ground them in the here and now, build that window of tolerance, and then you can kind of bring in that trauma into the room. It's really, it needs to be placed aside. It needs to be contained.
Is that phase 2 you were referring to?
It's pre the work, right? It's not even a phase, right? It's when you come into the room, I need to know that you can maintain a level of here and now. And if you can't even get there, then I can't even bring up past, future. We need to first grow the present, right? There needs to be a present moment for you to be here in order to contact with anything that from the past or anything that's trauma related, which is building window of tolerance, right? If I can tolerate here and now, then of course I can tolerate something that's upcoming or something that was. But until then we can't go there.
I'll just add one last thing. If there's somebody that has memories from, you know, times where they were verbal and they can't remember any of them, so that's an indication of repression. So it means that they're still in a place where there's so much avoidance that they're not ready for the work, and that in itself says they're not ready. If it's pre-verbal, then that's a different story. And it's a question of how can EMDR address pre-verbal trauma. But if it's later in life, then that's just an indication that, you know, they're still repressed and not ready.
And psychoed is so important here, right? Because you'll have clients who come in frustrated. I tried the work, it doesn't work, nothing works, this is hopeless, this is my last try. You say, hey, we have to first start somewhere. Like you can't go straight into EMDR, you're not going to be successful, and then you're going to get frustrated. Like you don't have capacity yet. And just that psychoed in the beginning is like, oh, that makes a lot of sense. Which is very helpful.
Yeah.
Interweaving EMDR.
Interweaving, you said?
Yeah, using them together, okay, and DBT together. Are there stages of the EMDR protocol that we shouldn't be using, you know, mindfulness and stuff like that, in a reprocessing stage, or can you use it throughout the whole protocol, or?
Yeah, I think so. I think EMDR. Okay, I'll end this. I think EMDR, like Shevi had mentioned, you know, prioritizes dual awareness, which just is mindfulness. It's a different term, so I think it's relevant throughout the entire process.
Thank you very much, Jonathan. Shevi?